Hi, everybody. This is Kara Thrasher Livingston with Senior and Disability Services Training, and you're in the right place if you're looking for our webinar regarding our tribal health organization and care coordination agreements. And we have a couple documents for us to look at here, and we have some guest speakers. So I just want to talk for a minute or two about the webinar and how to get the best out of it. Your webinar has two components. One of them is audio and the other is a visual. For the audio part, you might be listening to us on a telephone or on the computer speakers or your device's speakers. Either one is fine. On your device, which is either a laptop or a desktop or a tablet or perhaps even a smartphone, if you're listening to us over the internet, then it's just what we call voice over internet. There is no extra charge for that kind of audio. If you're listening to us on a telephone while you're viewing the webinar, that you will probably have already noticed that is a long distance number. It's kind of a random number assigned by the GoToWebinar system. It's not any special charges. It's just your regular long distance carrier. But you would see that on your report from your long distance carrier. For the visual part, you're seeing us on your computer or your device. The bigger screen that just says it's a document, just says CMS on the upper right-hand side. That's the actual webinar. You don't want to click out of that. That's our screen, and you can see the display there. Other controls that you see in the webinar are a little hand in a circle that you can click on to raise your hand or to in response to a question or something like that. You also will see a little square with an arrow in the middle. It's usually a red square with a white arrow in the middle. That is where you can open up a question area that you can go ahead and write to us. Your audio is joined in a muted status so that you can hear the presenters, but you won't be able to share audio. We have a nice big webinar today. We have about 50 people in the webinar, so it helps to keep it nice and clear, our audio lines. So I want to give everybody a chance to go ahead and practice using that question box. If you would just go ahead and write your name in the box, go look for the question area and write your name and just sign in for us real quick. If you want to sign in others who are attending with you in the room, perhaps there's a few people listening to the phone or something like that, you can go ahead and do that. But just to give you a chance to find that little question area and be able to enter something into it. And you can say hello to us and good afternoon to you. We don't really do a roll call here with the bigger webinars, but we have set the webinar so that you can see other names of folks who are in attendance to the webinar, okay? So since you're joining us as muted, then make sure and take advantage of the question area to write your questions and to interact, and our speakers will interact with you that way too, and we'll answer them in the webinar. We will have a recording of the webinar available that we'll put up on our YouTube channel for SDS training. And we'll give out the link and let everybody know. I have everybody's email address, so I can always get back to you regarding the information that was in the webinar here. Okay, so that being said, I'll go ahead and have our folks who are presenting or accompanying us in our virtual space go ahead and say hello. I'll start with here. Of course, I'm Kara with SDS. Go ahead.
This is Dwayne Mays. I'm the director for the Division of Senior and Disability Services, so I am here as well.
Okay.
And this is Renee. This is Renee Gahar with Tribal Health Programs in the Commissioner's Office.
This is Clarissa Moon, also with Tribal Health Program.
Good afternoon. This is Margie Bozzona with the Alaska Native Tribal Health Consortium.
Okay, great. Thanks, everybody. I have on our screen the letter, and we'll kind of start with that. So I will just go ahead and open the session to our presenters.
All right. Well, thank you. All right. Good afternoon, everybody. Wow, this is quite a crowd. So I'm glad everyone could take some time today. And real quick, before I go over the state health official letter, which you might have already had an opportunity to read through, I wanted to just give you a little bit of background on the tribal refinance efforts that we're going to talk about a little bit today. So I think many of you are aware of Senate Bill 74. It's the Medicaid reform package that the department has been working on with the legislature for the last few years. And out of that Senate Bill 74, there were actually 16 initiatives within that package. One of those is tribal health refinance, and several others are also part of the Department of Health and Social Services. I think we have 12 out of the 16. And then the 4 additional ones, other departments are also collaborating with us on. So today's webinar really is about the tribal refinance piece. And just to give you a little bit of background to the Senate bill was for state fiscal year 17 through 22. And as we enter state fiscal year 19, that was the year that the department built in collaborating with senior and disabilities providers. So in these last 2 years, Senate or state fiscal year 17 and 18, we started working with other providers that had higher dollar claims like the hospitals and long-term care and pharmacies and out-of-state RPTCs. So the reason we started working with those providers to begin with is we had pretty aggressive targets set by the legislature. So in 17, our projected target was 32 million, and then this year the target was 42 million, and then next year it goes up to 64 million. Since that time, the legislature has actually asked us to try and obtain 84 million in savings next year. But that original jump from state fiscal year 18 to 19 was really looking at senior and disabilities providers. It jumped from 42 to 64 prior to the next higher target of 84. But that $22 million target was really focused on waivers and personal care and some of the long-term care claims. And the reason that is now that we've already done some of these claiming activities with the other large dollar providers like the hospitals and pharmacies, senior and disabilities is really where the last bulk of a large general fund pot is sitting. And what I mean by that is I had put this out, or we had mentioned this in one of the e-alerts, but each beneficiary that's on Medicaid has a different type of percentage match that the state can gain. So as many of you may have heard, Native individuals that receive services at a tribal facility, the state can capture 100% federal match on that. Medicaid expansion is 95%. CHIP kids or Children's Health and Insurance Program is currently 88%. It's going to go down. But now that we're moving into the senior and disabilities, I see the screens moving a little bit. I'm not doing that, but as people want to read through that, I guess you can do that on your own computers. Is that how that works, Kara? Sorry to interrupt.
It's actually me. It's actually me doing it.
Okay.
So
okay, I was just going to say I'm not moving it. yeah, so you're not following anything on the screen that I'm talking about. But so where we're at is in the state health official letter, in order to meet these targets, the department through our section, Tribal Health Programs, has to meet 3 elements. And that first one is a care coordination agreement must exist between a tribal health organization and a non-tribal health organization. And then there must be a valid referral that the tribe referred that individual to the non-tribal site and that there's an exchange of records between the 2 entities. So I think there is some initial confusion because care coordination agreement in this scenario is truly the agreement between the tribe and the non-tribal entity. It doesn't have anything to do with the care coordination service or care coordination entities that senior and disabilities has. The verbiage sounds the same, but they're 2 very distinct things. And so what we're trying to do is we have Margie Bezona, who is our point of contact at Alaska Native Tribal Health Consortium, she is the main contact for the master agreement that details the terms between the tribe and the referring and the exchange of records to the non-tribal setting. So what we're looking for is for the non-tribal providers like yourselves and many others to work with Margie specifically and get those care coordination agreements signed. Now that's the first piece that the department has to prove up, that there are these agreements in place. And then the next two pieces, we are still working on the process flow with Senior and Disabilities to figure out how to obtain that valid referral and that exchange of records. And we've been working closely with Dwayne and his staff in order to figure out those next two elements. But the first big piece really is getting this care coordination agreement signed. Right now, we have just shy of 1,000 care coordination agreements in place. And those are in place with, again, like the hospitals, Regional and Providence and Bartlett and Central Penn and the non-tribal hospitals out there, as well as all of our out-of-state RPTCs, behavioral health providers, and pharmacies. So we're on track now to add the SDS providers to that mix. And I see that Kara pulled up the agreement. And again, this agreement is the Alaska Native Tribal Health Consortium and the Tribal Health Organizations agreement. The state is not a signatory to this. It is through Margie Bezona and her contacts at the Tribal Health Organizations. And, you know, I could give you all sorts of additional information. I did want to make a lot of time for questions today. But I do want to give you a little bit more information on how all of this claiming works, because some of the initial questions that we got from other providers, they were really wondering about how their claims submissions might change or how their clinical practices might change. And neither of those changed. So with this state health official letter, what the state has the capacity to do is claim up to that full 100% for Native individuals that received a service at a non-tribal site if these three elements, the care coordination agreement, the valid referral, and the exchange of records is verified. And so how we do that is we go off of prior period claims, which means all providers continue to claim and submit claims as they always have. So tribes submit their claims. You guys as non-tribal providers continue to submit your claims. Everybody gets paid based on the services you provided, and they were legit services, so you were paid. And then our team posed those claims from prior period quarters so that we can see where the Native individuals received services at non-tribal sites. And then we have to verify three things: the care coordination agreement, the valid referrals, and the exchange of records. So the burden of all of that proof is squarely on the state's shoulders, and the claims will not change for providers. They stay exactly the same. And then as far as audits are concerned, we, the state, have to prove up how we came up with verifying that there was the care coordination agreement, referral, validation, and exchange of records. That is not on the provider. The provider, you're subject to all the regular audits you've always been subject to, but this is not an additional audit issue for any providers. It solely is on the state's shoulders to prove up to CMS that we verified that these pieces were in place. So, and just to back up a little bit, the first year we did exceed our target, so we saved just shy of $35 million. This year we'll be at about $44 million. So it's quite a jump next year to go to $84 million. And the next big provider base really are the senior and disability providers. So that's our process in a nutshell and in about 10 minutes or less. So please ask questions. And if I can't see them in the box, I'll ask Kara to tell me who's asking, and I'll answer those. And also, Clarissa or Margie, if I missed anything, please chime in.
Okay. Thanks, Renee, for that great introduction and explanation. This is Kara at SDS. I want to go ahead and invite our attendees here to type your questions into the question box. If you don't see it, look for the arrow, the orange or red square or rectangle with an arrow to open it up and type your questions in. What are your questions regarding this topic? And we'll give people a minute or two to enter their questions. It usually takes a little bit for the questions to show up in the virtual space, so we might be a little bit quiet for a second.
Oh, and while they're doing that, I might add as well, this state health official letter came out in February 2016, and to date, Alaska is the first state to really be as aggressively utilizing this guidance for reclaiming. Other states that have a higher Native presence are just starting to get into really following the state health official letter and seeing if they can save dollars. And so far, I think Colorado, Arizona, Oklahoma, Arizona, Idaho, Oregon, and Washington are moving in that direction, but they've only claimed shy of $2 million. So the state of Alaska really has been trying to move forward, basically because the legislature gave us these targets, and these dollars are already out of the budget. So whatever we're not able to save through this effort, it would be a cut somewhere else in our budget. So far, we've been meeting the targets and or exceeding those, and we have a process in place that's, as far as we can tell, audit-proof. And so we're moving forward with increased targets, hopefully not much more than this next year, though. 84 is a pretty aggressive target, but we're shooting for it.
Okay. So this is Kara again. Sounds great. I'm going to go ahead and read out the first question here. What percentage of current SDS recipients are estimated to qualify for 100% FMAP?
So if that question's asking how many natives are currently in service through SDS providers, we're still working on those numbers, but Clarissa, remind me, it was in the 3,000 range?
Yes. Right now, our tribal population is around 40%. So if we do the same percentage, it will probably be 40% of the current SDS participants, but right now it's coming out to around 3,000. A little over 3,000.
Okay.
And that's on average, just so folks know, with the entire Medicaid population at a little over 200,000, we say about 38 to 40% are natives. So that's polling true as we look at the numbers for SDS clients as well, native clients.
Okay. Related to that, are these cases brand new referrals, or can they be people that the agency is already serving?
They can definitely, it's going to be a blend of both. So I mentioned a little earlier that we're working on getting these care coordination agreements in place, and we're also working on that referral validation and exchange of records. And so after we have a little bit more time with SDS, we'll be requesting another webinar like this. And we see referrals as not just those that are coming in new at intake, but also those that are renewing in the system. So if you think in terms of Native individuals have been getting services around the state for decades. So those referral patterns are already in place with existing providers. We just have to prove up that tribal health organizations are a part of that planning process. So it's both. We'll be taking folks that are coming in through the new intake process, as well as trying to develop that re-enrollment process to re-engage tribes into their Native beneficiary services. Not taking them over, but being a part of that process.
Okay. there's a statement that says the agreement is very focused on medical services, and we, meaning home and community-based waiver and long-term services and supports providers, do not provide any medical services. So,
right.
If I understood you right, when you talked about it before, that medical providers were part of the first outreach, if you will, to bring into this system. And so now it's kind of the same umbrella we already knew about. Our services are awarded to folks who come in through level of care, which is based on medical needs and Medicaid rules. So it's just another facet of the same effort.
Right. Right.
Okay.
And just to add on to that a little bit, Kara, if you think in terms of services, individuals are eligible for the whole array of Medicaid services once they're in. So while the set of providers that is on this call today provides those waiver services, like Kara said, that level of care is medical necessity getting in. But those individuals are also receiving dental services, medical services at the hospital, and they'll continue to receive those. It's all part of their overall package that Medicaid funds. So while waivers are a little bit different, they are still part of an overall medical package.
Okay. Questions about the concept of referral. There's one that says, as a care coordinator, my clients aren't always referred by their primary doctor, yet they still qualify for services. With a new contract, would a referral be required to fulfill these requirements? Some of my clients are Alaska Native American Native and have never had a referral. Would this be an issue, or could they just get one from their primary provider?
So that's twofold. We do have to prove up that there is a valid referral and exchange of records in place. So in those scenarios, that's part of what we're working with SDS on, is to figure out where is that door that either the doc can do a referral or that the tribal health organization can be a part of the future planning process. But there's different ways to look at how tribal health organizations become involved. So just if I can give you a couple of 4 instances to let you know how we did this in other service areas. So let's think of those areas like here in Juneau. I'm in Juneau. I think some of the folks on the list are included there. But SEARCH, Southeast Regional Health Consortium, is the tribal health organization here. They do not have an emergency room in Juneau. So there's standing orders or a transfer agreement for Native beneficiaries to receive their services at Bartlett Regional through their ER. So there are some scenarios or criteria that we can try and talk through to see if individuals, because tribes haven't traditionally provided waivered services, tribal members have gone to non-tribal settings. So with that, there's an implied transfer agreement between tribal organizations and non-tribal. We still do want to prove up that valid referral and exchange of records, and it may have to occur at re-enrollment, where the tribe is reintroduced and may become a part of that planning team for that Native individual. And that was a long response, but please ask follow-up questions, because this is pretty detailed, and myself and my team have been doing this for a few years, so I can start talking pretty quickly.
Okay, great. Thank you.
Yeah.
Next question says, if I understand correctly, tribal health organizations can enter into care coordination agreements with multiple providers for the same service, as long as that is a service that is not provided by the tribal health organization. Is that correct?
Let me answer that twofold. In this scenario, for instance, would be the larger waiver entities that provide multiple waivered services. So if Alaska Native Tribal Health Consortium were to enter an agreement with, say, HOPE or ARC or Assets that provides multiple service categories, we would only need that one agreement in place because it would cover the services that are provided under that entity. So, and then the second part of that question, even if a tribe does provide a certain service, if that tribe were to enter an agreement and a referral to a non-tribal and there's an agreement in place, it's still a legitimate claim.
Okay. Thank you. Other questions? Does us signing an agreement with ANTHC cover search and the other tribal organizations?
So, Margie, I might have you answer that because it is a blanket agreement, but maybe you could answer that from the tribal perspective.
So currently, Search did sign on to Alaska Native Tribal Health Consortium's master agreement. So the answer to that would be yes if you're part of Search.
So, if I can follow up to that too, this is a master agreement, and Margie has worked with one or all of the 18 tribal health organizations, and they've signed on. So if you were an individual entity, you wouldn't have to sign 18 separate agreements. You could sign this one master agreement.
Okay. Next question says, will recipients and or providers get information in regards to the amounts the state is billing on their behalf?
Okay, I need to back up a little bit there. We're not billing for anybody. We're looking at prior period claims that were already paid to the providers, and we claimed whatever percentage we were eligible for from the feds. And so what we do after we prove up a care coordination agreement, a referral, and that exchange of records, we can claim, let's say that individual was we paid a provider and we were reimbursed by the feds for 50%. If we validate those three elements in the state health official letter, we can claim the other 50%. So we're not billing for anybody. We're going back and we're doing prior period claims adjustments. But what we do have and what we report to the legislature each year is where the dollars are that we captured. So we can say from the pharmacies, we captured $800,000. From case managed kids, we collected $1 million. And I'm throwing those out there as examples. Those aren't actuals. But we do have the ability to, at the end of the year, determine if we met that $22 million mark with senior and disability providers, if that's your question.
Okay. This question is thinking about the agreement itself. Is it possible to have an agreement that closer matches services provided by home and community-based waiver agencies? I'm not comfortable signing off on an agreement that says things like we agree to, number 2, medical control during the transport will be assumed by the medical director of the transport service in EMS situations. Just looking at the agreement part.
So Margie, that would be a question for the tribal health organization, and she may have to take that back to her legal counsel. But I can say that that particular piece is put in there because at any given time, your waiver clients included could end up in a medevac scenario. And those medevacs then are under a different type of agreement because they're non-tribal as well. But Margie, you might want to tag on a little bit there.
You're right, Renee. Exactly what you said is, I think when this agreement was created, it was more global for the full care of the patient. However, if there is a facility that would like to make changes, and there has been some that have sent in some edits, I have to take that to our general counsel for a review. That's the process.
Okay. Okay, other questions on, let's see. For FY19, 40 million in savings means identifying 80 million in current plan of care value. Since they are already receiving 50% FMAP, is this correct? How soon can waiver providers expect to sign agreements to allow target savings ASAP?
Okay, can you read that first part again? I missed the 80 million thing.
Okay. It says for FY19, 40 million in savings means identifying 80 million in current plan of care value since they're already receiving 50% FMAP, which is talking about how, if I'm getting it right, talking about how we receive 50% match from our federal oversight for the waiver services that we provide. How soon can waiver providers expect to sign agreements to allow target savings?
Okay, so let me back up a little bit. So in Senate or in state fiscal year 19, our original target was 64 million, and it went up to 84 million. But that original difference between state fiscal year 18 and 19 went from 42 to 64. So waivers were projected in there for a $22 million savings. So depending on what the total spend is in senior and disabilities, only a portion of that spend is going to be on American Indian, Alaska Native, and then only a percentage of that is actually going to be able to prove up on these three elements: the agreement, the validation, and the exchange of records. So even though, we could look at a budget and say, okay, there's 80 million, so 40 million is what we'd be getting, we still have to prove up all three of those elements are in place, and in some cases they're not. So if there are 3,000 individuals that are receiving waivered services that are Native, that doesn't mean that all 3,000 of their plans of care are eligible for reclaiming if we can't validate those three elements. So when we're looking at things, we also aren't going off just the 50%. So if you're looking at the 84 million total that we've been given, that isn't just $42 million in savings, because some of those percentages are very different. We have, I think, just over 40,000 people on expansion. So 38 to 40% of those would be Native. And their services, if we proved up these three elements, would only be eligible for that additional 5%, not 50%, because expansion's already at 95% federal match. Some of those are kids. Those kids are already at 88%, so we're only getting 12%. Where we get the largest savings is if they're regular Medicaid and they're 50%, but not all of those are there. So we can't just take one number, chop it in half, and think we get that from any given service provider, because we still have to prove up those referrals and those exchange of records. And that's a lot harder than it sounds, because there's so many records out there. So right now, we would encourage folks to sign the CCAs and get those back to Margie as soon as possible. And that meets element number one. And then we continue to work on how we're going to validate those referrals and exchange of records.
Okay. Once the agreement is completed, where do they get sent back to?
And Margie, maybe you can give folks your phone number and your email again.
Sure, of course. I would be happy to work with each of you individually to send out a Word document to make it easier for you to edit. My direct line is 907-729-2812, and my email address is mbezona@anthc.org.
Okay. All right. Are we saying that a provider would have to do a referral for each waiver service? that's under the waiver program? A couple of examples.
No, we're not requiring that. And those referral validations, that's part of what we're still working with Dwayne and his staff on. And one of the concepts is when a person comes in to waivered services and there's the person-centered planning that goes into coming up with that plan of care, those the participants that are on that planning meeting are considered folks that are part of that referral, and then those services are provided. And then if one of the tribal health organizations were part of that planning team, they would be part of that referral, and they would also be a part of those records. And that's part of what we're trying to determine if that will be placed in harmony, and if we can see those team members and referrals for those services. Now, in this case, let me expand on that a little bit, because in this case, waivered services all fall within that plan of care. So whatever's on that plan of care is what we could claim on behind the scenes if that referral's there. Now, if that individual were to go somewhere else and get dental services or get glasses or get stitches or get a blood test, those are all separate medical referrals. But the waiver itself for what's included in the plan of care is one referral.
Okay, thank you. Next couple of questions here. They might be about the same thing with some differences. So question says, if you're doing prior period claims adjusting, yet aren't getting someone started until the new plan year for persons currently served, wouldn't it take some time to be able to show a measurable difference in terms of budget to the legislature? Next question is related. It says, if you're attempting to recapture back billing and the referrals weren't made prior to the agreement being signed, they wouldn't qualify. Or if one is signed today, you could recapture the other 50% of services rendered to the Alaska Native population.
Okay, that's a lot of questions, but I'm going to do my best to answer those because I can't see them on the screen. So I'm going to start, and then you tell me what I missed. So
okay.
A couple of things. Yes, we projected these savings for state fiscal year 19. So we certainly want to capture what we can as soon and as close to July 1st as possible, keeping in mind that July 1st is the start of a quarter that ends on September 30th. So that quarter we won't be looking at until January timeframe in 2019 because we go off prior period claims. Now, we do have to prove that that referral was in place at the time those services were provided that we're looking at those claims. If it's not there, we can't claim. So when we're looking at reporting to the legislature, keep in mind that we continue to do this whole process with transportation, with medevacs, with pharmacies, with hospitals, with out-of-state RBTCs. So we continue to accrue dollars and efficiencies in those categories because they needed time to ramp up too. And now they're a couple years in and they're ramped up. So we'll see increased savings there. We indicated that waiver providers and senior and disability providers were coming on in 19, but that doesn't necessarily mean that we're going to get 100% savings in that first year that we're kind of kickstarting this and getting it going. So in terms of reporting to the legislature, they give us those targets, and we have to meet those targets with the providers and service categories that we already have in place with this new process, implementing the guidance from the state health official letter. So I think I got most of that, but tell me what I missed.
Renee, the part you missed is going back all the way to 226, that CMS gave us the approval to go back all the way to 226.16 to do reclaiming.
Correct. And so what Clarissa's saying is the department can go back 8 quarters to claim anything that would have had these 3 elements. So I think part of the concern with senior and disability non-tribal providers might be that, the referral may not be there. If it is, we can go back 8 quarters. If it isn't, then at whatever point in time that there is a referral or an exchange of records, we go from that point in time forward. So for instance, let's say we come in and we look at claims from, I'm just going to say Hope, and we say, here's these 10 natives that had services. Of those 10, we can prove that 2 had a referral going back 8 quarters, and there was an exchange of records between tribal and non-tribal providers, and the agreement was backdated. In those instances, we could claim for those 2, but we can't claim for those 8 until at some point in the future that there's a valid referral and exchange of records. So what I'm kind of getting at behind the scenes is this is a manually intense process of pulling hundreds of thousands of records and actually going through this with each individual. And at this point, each quarter, we're looking at about 5,000 to 7,000 individuals that we have to go through and verify the agreements in place, the valid referral, and that exchange of records across any and all service providers they might have received services for previously. So in many cases, like any of us, I go to the eye doctor because I need glasses every year. I go to the dentist, I might need stitches, I might have blood tests, labs, I might be in the hospital. That's 6 different providers that need to go through this whole process. So multiply that times 5,000 individuals each quarter, and that's the manual intensity of what we have to prove up in order to even submit a valid claim to CMS.
Okay. Good clarification.
Okay.
This is Kara again. There's a couple of thematic questions here, meaning like folks are kind of having the same thoughts. Concerns about, I guess, describing the involvement of the team and contributors or tribe/other contributors. Our waiver providers and care coordinators have a responsibility to make a person-centered plan using a person-centered process. And so it's my understanding that nothing about that changes. Will our medical providers be expected to be at planning meetings literally, or is this really, like I said, nothing really changes? It's just a matter of these agreements following, with the three supporting concepts that you've been talking about.
Well, the only thing that's going to change if we can prove this up in the planning process is that a tribal health organization would be involved in that upfront person-centered plan, whoever is a part of that team, whether that's going to require a release for that individual to request their tribal health organization, or if it becomes a part of the process that care coordinators or providers include tribal health organizations. It does not have to be a medical doctor. It could be a case manager or someone from the tribal health organization that would be involved in that individual's upfront planning and or renewal. That's the only change. And, I would say that in most person-centered plans, people are coming and going from that process over the course of, from this year to next. As you add or delete different people in this scenario, it would be adding a tribal health organization member back into that Native beneficiaries plan.
Okay, good clarification. Thank you. What other questions are out there? That was the last one on the list there. We're coming up at about 10 minutes till the top of the hour, so I think maybe we just have time for 1 or 2 more questions. I'll give you a little bit of time here to write in something.
And Kara, thank you for reading these. I see it on my screen, but it's so little and I can't expand it, so thank you for reading them for me. I just
Sure.
see.
Yeah, absolutely. And plus, we get our audience members can't see them, so we read them out so folks can think, learn, and things like that. It's all good. If people have questions about this topic, I'd be happy to receive those questions. You can email me, and I can forward them if I need to the team. Would that work okay? Or
sure, that works for me. Yep.
Okay. And if you have questions about the agreement, I did send out the contact for Margie, the phone number and email, and everybody has the e-alert too that they can go back to. Okay. I'm not seeing anybody right now. Go ahead.
I'm sorry, Kara. I believe we missed 2 questions from the very beginning.
Okay.
The question from Christine Schultz and Jean Kincaid, I don't believe were answered.
If we are a tribal organization providing the services already, Norton Sound Health Corporation, then there is nothing that we need to do now. What would we need to do now?
Well, if you're providing all waivered services for all your Native beneficiaries in that region, then you're covered. But there's probably some scenarios where you have beneficiaries from your region going somewhere potentially to receive services. So in those cases, we would want to work with whichever non-tribal you might be referring to.
Okay. And then Jean's questions were about the agreement focusing on medical services and then asking for possible changes to the agreement so that they match closer to what home and community-based waiver providers do.
So I think Margie answered that when she had indicated that folks could work directly with her if there were sections that you wanted to modify.
Okay.
This might be also the time, Renee, to clarify that any Medicaid paid service is included in the state health official letter, what we include as part of reclaiming.
Okay. All right, thank you. There is a question on the bottom here. It says, so right now, care coordinators can't move ahead with signing the tribal agreement until it is decided where the referral is to come from. Also, you said a tribal representative must be involved and listed as part of the plan of care.
So the first step is we would really like folks to start working with Margie. And if you're interested in partnering with them to get those care coordination agreements signed, that's the first step. And like I said, we have 1,000 agreements in place. And so this is sort of the outreach effort we did with the pharmacies and with the hospitals. We had those first upfront discussions explaining the process. And so that first step is, you know, getting these signed, and that's proof number 1 done. So then we're still working with Dwayne and his crew on how we can determine referrals and that exchange of records. And so in some cases, those referrals might already be there for individuals that the non-tribals have in their programs. In other cases, we're going to have to determine how that works. But all 3 of these don't have to happen all at the same time, because we are just now starting to look at creating this savings piece from this provider type. So for instance, I had mentioned earlier that this first quarter, July through September, we won't necessarily be looking at that quarter for about 6 months because we look at prior period quarters. So that gives us time to get this process in place and work with our liaisons at SDS and with SDS providers. The goal being, though, like you're saying, we would encourage that a tribal member or a tribal health organization be a part of that planning process. Whether they will in every case, it's unlikely. But in a high percentage, we would love to see that, because that would be the easiest way to prove the referral. And it actually is wrapping the tribal individual back into their health organization.
Okay, good clarification. And so the second part of it is a tribal representative must be involved and listed as part of the plan of care, eventually for our care coordinators.
You know, again, we're kind of open to suggestions, and that's what we're trying to work through with SDS. That would be the best way to, again, prove the referrals in place and to have the tribes being a part of that planning process. So, you know, that's the ultimate goal, whether we have that across the board or in certain entities, you know, that remains to be seen. But if folks have other ideas about the referrals, in some cases it's cut and dry with some of the medically necessary services for kids. There's a doc doing a referral. That's a little bit different than someone in other waivers that is already in the system and might need a reconnection to the tribe. So there's lots of different scenarios.
Got it. Thank you for the further clarification. Okay. It's 5 minutes till. So I think what we should probably do is work on closing our session. I know some folks have other meetings that they have to get to. What I'll do is I will leave the webinar part open in case there are questions that you wanted to put into the session, and I'd be happy to forward them to our team. And you can always send questions to if you have questions about the agreement to Margie. And if you have questions about the topic that you want to send to me, Kara at training, you can do that, kara.thrasher-livingston@alaska.gov, or you could even send them to our training inbox, which is sdstraining@alaska.gov. Okay? So thanks everybody for attending, and we'll have a recording available for you up on YouTube so you can go back and listen again. Thank you to our presenters for being a part of sharing this great information. It's exciting, and we look forward to working with you again for further outreach and sharing information with people. Look for emails from me if people have follow-up questions they'd like to share. And I appreciate everybody's time here this afternoon. Thanks for joining us. You're welcome to click out of the webinar when you're comfortable to do so. And after a couple minutes, I'll go ahead and sign out myself. All right, so we'll close our audio part at this time. Thanks again, everybody. Goodbye for now.
Thanks, Kara.
Thank you.